talk about. So the first question, severe burning pain, tactile hypersensitivity. They had zoster the left chest. What term explains this phenomenon? And the answer, of course, is allodynia,
Okay,
which
perfect.
is just having pain from something that should not be painful, such as the bed sheets, the shower, and it's dorsal horn sensitization, allowing tactile A beta input to be perceived as pain. Hyperalgesia is just increased pain from an already painful stimulus, such as a pinprick. Hyperpathia is delayed, often explosive response after repeat stimulation. And dysesthesia is just unpleasant, abnormal sensation, not necessarily pain. Anesthesia dolorosa is pain in an area of sensory loss. The boards will ask you about that in relevance to trigeminal neuralgia, typically.
Okay, in relevance to trigeminal neuralgia,
Yeah,
the
you may
anesthesia.
see it in neuralgia paresthetica, but typically anesthesia dolorosa is something that goes along with the trigeminal neuralgia.
Okay.
And the non-painful stimulus allodynia once again, and if it's just something that's painful but it's exaggerated pain, it's hyperalgesia. Okay, question two. They want to know which receptor is involved in dorsal horn excitability, poor sleep, fatigue, and decrease in inhibitory signals. The answer is NMDA.
Oh, okay. I actually had GABA B, so that okay, so it's
Okay, so you
NMDA.
learned something.
Okay.
The NMDA receptor activation is central to wind-up long-term potentiation, dorsal horn plasticity, and central sensitization. Chronic widespread pain syndromes involve augmented central processing, altered descending inhibition, facilitation, sleep disruption, psychosocial contributors. GABA B is a signaling inhibitory neurotransmitter. Mu receptor mediate opiate effects and are not the central wind-up receptor. Muscarinic and D2 dopamine receptors are not the classic board-tested receptors for central sensitization. So for the boards, when they say central sensitization wind-up opioid-induced hyperalgesia and ketamine, think NMDA.
Yeah. Okay.
And then you have the little illustration here. And by the way, I'm going to give you a copy of the slides as well as of this recording.
Oh,
So,
okay.
so
Okay, perfect.
you're going
Okay.
to
So
have
now
everything.
no,
Yeah.
okay. Okay.
So you could review at your own pace.
Okay, awesome.
Can I continue?
Yeah, thank you.
Okay. Patients on escalating opiate doses for chronic low pain become worse, diffuse pain beyond the original place. More opioid gives only brief benefit and then worsens hypersensitivity. The answer is opioid-induced hyperalgesia. It's a paradoxical increased pain sensitivity caused by opioid exposure. There's less relief as the dose escalates. Mechanisms: NMDA activation, descending facilitation, spinal dystrophin, and glial neuroimmune signaling. Pseudo addiction improves when the pain is treated. Physical dependence describes withdrawal when cessation of the drug. Acute withdrawal causes autonomic symptoms and myalgias after dose reduction. Somatic symptom disorder should not override a classic medication-induced pattern. So board pearls, tolerance, same pain, less effect. Opioid-induced hyperalgesia, spreading pain and worsening sensitivity with escalation. It's like that IV drug abuser who gets severe pain upon placing an intravenous line in the ER.
Uh,
Okay, next one. Diabetic with distal symmetric neuropathy, major depressive disorder, duloxetine, right? You're going to kill two birds with one stone, hopefully.
Yep.
SNRI drug, and it's indicated for neuropathic pain at the feet and diabetes. Diazepam, carisoprodol are sedating and non-neuropathic um, analgesics. Hydrocodone, not the first line therapy for diabetic neuropathy. Prednisone is not chronic therapy and can worsen hyperglycemia. So just carisoprodol, just a testable question. What's the problem with that drug?
Carisoprodol. Um,
So it's habit forming.
oh, okay.
And
Okay.
there's neurotoxic metabolite. I believe it's metaprobate, I think it's called. Hold on, let me just double check that for you because I'm drawing a blank here. It's a big testable question here. So
Okay.
Yeah, it's a meprobamate. Okay, it's an active
Okay.
metabolite with sedative and anti-anxiety properties. Um, it is a controlled substance, Soma 4. So when the FDA, I mean, they're still kind of going after doctors who overprescribe, of course. But when it really started with the opiate benzo mix, it was really the deadly trio they were touting, which included the Soma. So Soma, benzo, and opiates were like the big no-nos um, for the FDA. So I'm just going to share my screen again. I'll just share the whole desktop so you can see what I'm doing when I'm doing any Google searches with respect to the terms I'm looking up. Okay. 63-year-old man is being converted to methadone. He has syncope, history of macrolide antibiotic exposure, and baseline QT. So macrolides and methadone both increase QT, and QT can lead to torsade du poids.
Uh-huh.
Um, Other problems, electrolytes, structural heart disease, um, distract pulmonary fibrosis, renal cortical necrosis, and severe thrombocytopenia and hyperkalemia are not related to methadone toxicity. So just be mindful of methadone and QT risk.
Okay.
And
Yeah.
NMDA activity, of course, is always tested. So next question. Buprenorphine for opioid use. I'm going to move a little quicker here because I feel like we have a lot more to cover. So if you want me to slow
Okay.
down, just tell me, please.
Okay.
So buprenorphine opioid disorder, what's the deal with this drug? So just keep in mind, high
It
affinity
was
partial
okay.
mu
It was
agonism. So going back, that is when you have the hydrocodone, that it will easily displace buprenorphine from the receptor. The most relevant property is the partial mu agonism, the high affinity. So it tightly binds and can displace full agonists and may precipitate withdrawal if initiated too soon in an opioid-dependent patient. Full agonists may require careful planning because the ordinary doses may be blunted. It is not low affinity. It's not a pure kappa agonist. It's not an NMDA antagonist and not an irreversible blocker. So just remember, buprenorphine, high affinity partial mu agonist. There's ceiling respiratory depression, but it can precipitate withdrawal.
okay.
Yeah, that one was tough, I thought.
I think well, you know how you like will hold that for 2 weeks, like right pre-op or whatever, if
Hmm.
you're but you can overcome it. So yeah, I was between E and B, um but you can overcome it, right? But the withdrawal is precipitated because
It's
of
knocking the opiates
of
out.
the
Now,
of the
I gotta
partial.
tell you, I have a little bit of a problem with this question. So it's not all you, this one,
Okay.
because the
Okay.
response is giving you, well, if they were on opiates, then you start the buprenorphine, what happens, right? You're knocking, it's saying that you could displace the full agonist, but the question
Right.
is relating to like if you do the hydrocodone, well, it doesn't really tell you when. It just say if the hydrocodone displaces the buprenorphine. So the resident is wrong, right? The resident is saying the
Yeah.
hydrocodone will displace the buprenorphine, but the answer is saying
Right.
no. The buprenorphine is a high affinity partial mu agonist.
Okay.
Okay, so patient receives a peripheral nerve block and shows signs of local anesthetic toxicity. Um, so the typical first um, signs are CNS depression. They just may be a little disinhibited or obtunded before it gets to seizures and cardiovascular collapse. I'd say there's a lot of testable points here. You get seizures, coma, conduction delay, arrhythmias, hypotension, cardiovascular collapse. The bupivacaine usually is associated with the cardiac muscle. You need a substrate for that bupivacaine to bind to. That's the lipid emulsion therapy. And if there is a seizure, what do you treat the seizure with? That is a board testable question. What would you use?
Intralipid.
No. Interlipid treats the
Oh,
toxicity.
the last. Oh, the seizure.
How do you terminate the seizure?
Benzodiazepine.
Right. Don't use propofol because of it could depress cardiovascular cardiac output, and the patient could become more hypotensive. Um, and you want to get this patient to a hospital that has bypass because it's going to be a long code if the intralipid is not working right away.
Yeah. Okay.
What local anesthetic has the greatest cardiotoxic potential because of avid sodium channel and slow dissociation from the cardiac channels? Well, we just talked about that. That's bupivacaine, of course.
Okay.
Chlorprocaine is rapidly metabolized by plasma cholinesterase, testable. Lidocaine and mepivacaine are less cardiotoxic, and testable prilocaine is associated with methemoglobinemia.
Okay. I'm gonna write that down because I think the prilocaine. I think of that hurricane, but that's good.
Okay, a 58-year-old man, acute quadriplegia after cervical epidural. I think it's pretty obvious. He he had an infarction, a
Mhm.
stroke from an embolic phenomenon, usually from vasospasm or particulate steroid being embolized into the medullary or vertebral artery circulation. That's why we use dexamethasone, which is a non-particulate steroid in cervical transforaminals, and now I do it in lumbar transforaminals as well.
Uh-huh.
That's testable. That's standard of care type thing.
Yeah. Yeah.
Okay. Another corticosteroid we talked about this already, dexamethasone is non-particulate, and I don't think there's much else to discuss with this one. Um, Severe back pain, bilateral leg pain after epidural. So basically, they're describing a possible hematoma, right? So the
Hmm.
workup is urgent MRI and neurosurgical evaluation. You're not going to do another injection right then and there. It doesn't make sense. EMG, well, how long does an EMG take to show findings? Like 6 weeks, right? So that's not going to be useful. This is an emergency.
Yeah. Okay.
Okay, and
Perfect.
oral steroids neither. This is another basic question. So, I mean, you're in practice, right? So you know the rules of Medicare for medial branch box. I imagine they might just ask something about that, but this, I mean, if you're practicing pain, I think this is obvious. Just
Yeah.
okay.
It is.
This question I wasn't a big fan of. Teaching points. L5S1 is the level that has three nerves innervating it, right? The L4, L5, L4 medial branch, L5 dorsal radius, and S1 ascending branch.
Okay.
Not going to spend too much time on this question. Contrast vascular uptake before. Well, if you get vascular uptake, I mean, this is obvious. Reposition your needle. I mean, this I
Yeah.
thought was too obvious. So, but every now and then they will ask an obvious question. Severe burning foot pain after surgery, swollen model cooler than the other side, allodynic and stiff. What's the diagnosis?
I thought this was CRPS.
Yeah, agreed. So the answer is C. You're looking for asymmetry with the other side. I think this is a pretty obvious question. You could review that at your own pace if you need to. Now we have triamcinolone, duloxetine, trazodone, and the patient gets agitated, diaphoretic, diarrhea. So this one, it could be easy. It may not be so easy because there's a lot of, a lot of us are not really like talking about neuroleptic malignant syndrome versus serotonin syndrome on a day-to-day basis. So what's the answer? It is serotonin syndrome.
That's what okay.
Yeah, serotonin, tramadol inhibits serotonin norepinephrine reuptake in addition to weak mu agonism. Combining it with duloxetine and trazodone creates serotonergic excess. See, for me personally, duloxetine and tramadol, it was definitely serotonin syndrome. Now, trazodone, that was to me a little bit of a confounder because I don't use trazodone, so I'm not really so up on it. But yeah, clonus hyperreflexia is something you see with these patients. Opiate withdrawal lacks clonus hyperreflexia. Malignant hyperthermia, you need to have a trigger from the anesthetics, see succinylcholine or a volatile anesthetic. Neuroleptic malignant syndrome has lead pipe rigidity, and it's more of a dopamine blockade, which you don't see with these drugs. Anticholinergic toxicity has dry skin, urinary retention, mydriasis, and delirium.
Okay.
Postherpetic neuralgia, thoracic burning pain, allodynia. I thought this was a give me.
Yeah,
Topical.
it was.
I mean, this was a little too easy. Um, Chronic low back pain, severe disability, mild degeneration, MRI changes, and believes walking will permanently damage his spine. Well, I also thought this was a gimme. Fear and avoidance, catastrophizing,
Yeah.
right? You need to address all that. Chronic pancreatitis, another easy one, right? Celiac plexus block.
Exactly.
So,
Hmm.
what are the side effects of celiac plexus block? What are the two most
Well,
common side effects tested on the boards for celiac plexus block?
is it something with with the aorta? Although you can do a transaortic approach, so I guess it wouldn't be hitting the aorta. Um,
I actually do the intra-aortic approach where we go through
you
and through
do?
the aorta. So you need to just as an FYI, you need to scan the aorta, make sure there's no dissection, calcifications at the level you're going, and
Okay.
um, use contrast, of course. But it's actually, when done properly, it's a pretty safe and easy technique to do because the plexus is right there on the other side.
Yeah. Two biggest complications. I should know this, but I don't. I don't know.
Okay, well that it's diarrhea from the
Oh,
sympathetic
okay.
vein and hypotension.
Okay.
You know, these questions, some of them might be really easy, but they're good guiding
Yes.
just to bring up topics that we may need some work on. So
Yes.
that's typically what they'll ask you. Now, let's say you could not do a celiac plexus block for some reason, or because you just haven't done one in 10 years, which is more realistic, right? Because we're not doing these every day, a lot of us. And the patient comes in with this sort of picture. What can you offer them in your office with a C-arm that might help them with their condition? What type of block?
Instead of a celiac plexus block for pancreatitis.
Yeah, or pain from the pancreas, cancer or pancreatitis.
This is good because oncology is something that I definitely want to do. So I'm glad we're
Oh, good.
chatting about this.
So this is like a workaround.
Okay. With the C arm, I'm trying to think.
Okay, I'm gonna make it. I'm gonna give you a hint.
Ga-
What?
ganglion
Which one?
impar? The ganglion impar?
Absolutely not. The
No.
the
Okay.
ganglion part is the coccyx. It's for that's for perennial pain, general pain. That's the last sympathetic ganglion. It's also known as ganglion of Walther. It's a unilateral. It's a central ganglion anterior to the coccyx, posterior to the rectum, where the sympathetic chain converges. This is more proximal to the celiac plexus. So, what forms the celiac plexus?
Mm,
I'll tell you, it's the
not sure.
splanchnic nerve. So you do
Okay.
a splanchnic nerve block or a spine, and that's around T11, T12. So this is like doing basically a lumbar sympathetic, but really a thoracic sympathetic block at the level of T11, 12. So you're getting the retrocrural celiac plexus higher up, where before it becomes the celiac plexus. You're getting it at the splanchnic nerve, which contributes to it. This can also be radio frequency ablated. So I would you do it, or I suppose alcohol, but you gotta be very careful, right? Because you're close to the spine. But
Okay.
this is a useful technique. I don't do much of this, but this is something I have done, and it can help people with pancreas pain, and it's a little more it's more accessible than the celiac plexus block.
Okay.
So moving on. Intrathecal gadolinium injection. Okay, so the AmSurg Center ran out of Omnipaque. Uh, so what are you going to do with your epidurals? Can you use gadolinium?
I don't think you can.
Hell no.
Never did.
There are cases. There was a malpractice case. I wasn't an expert witness on this, but I just heard about it where they did that, and then I think the patient died. I mean, neurotoxic. If you get intrathecally with
Oh my.
gadolinium, headache, confusion, encephalopathy, seizures, neurologic deterioration, it's a bad idea.
Okay.
And then by the way, I've been at AmSurg centers where the staff is like, "Oh, you don't have Omnipaque here? Take the gadolinium." Okay, so
Oh my.
yeah, so that's happened. So yeah, that don't do that. Um, okay, so um, The nephrogenic systemic fibrosis is a systemic renal risk concept with the acute intrathecal presentation of neurotoxicity. It's just a distractor here. Hepatic necrosis, fibrosis, hyperglycemia, renal artery thrombosis are not classic gadolinium issues, so don't even worry about that. Chronic leg pain after lumbar fusion. Evaluate for spinal cord stimulator. So, I mean, this is obvious. Do a trial. I mean,
Yeah.
this is, yeah, I'm not even going to waste
Yeah.
time with that. You need, during lumbar facet ablation, which neural structure is the intended target? Well, this is also obvious, right?
Yeah.
Your
Medial
branch. We
branch.
all know that, except for the dorsal ram IAL5, and if you decide to do the ascending branch at S1. Um, gelatinosa. So where is it? It's the dorsal horn, Rex lamina 2. Did you remember that
It's the
one?
dorsal horn. Okay. I couldn't remember if it was dorsal or
Yeah.
ventral. So it's dorsal.
It receives small fiber nociceptive input, contains interneurons involved in gating, modulation, opioid-mediated analgesic mechanism. The ventral horn contains motor neurons. Spinothalamic tract is ascending pain temperature pathway. Internal capsule and cerebellum are supraspinal structures related to lamina 2. So just remember substantia gelatinosa, lamina 2 dorsal horn for pain modulation.
Lamina 2. Okay. Right.
Okay, those ketamine, I mean, let's ketamine and MDA, we know
Uh-huh.
that.
Yeah.
Adverse effects, dissociation, hallucination, hypertension, tachycardia. Other things about ketamine, it can increase intraocular, intracranial pressure.
Mhm.
It maintains blood pressure. It doesn't really cause respiratory depression. It's not a mu agonist, not a GABA antagonist, or a dopamine blocker. And you need to cover the psychological effects or the bad trip with either a benzo or a little bit of propofol when you're giving
Mhm.
it. Um, Anyway, painful diabetic neuropathy, duloxetine, right? I mean, that's pregabalin is also
Mhm.
effective, but it can cause weight gain, edema. What are the other side effects? Leg swelling, right?
Oh yeah, yeah.
That's a big one. Okay, opioid, classically associated with serotonin risk because it inhibits serotonin and neuron. Well, this is a sort of an opioid, right? It's tramadol.
Yeah.
Okay, we know that
Tramadol.
one.
Yep. Yep.
Same thing, another easy one, positional headache after epidural, posterior puncture headache.
Yeah.
So if the blood patch doesn't work, do another one. They might ask you that, right? The first one will give you
Okay.
85% of people relief. The second one will give you like 92%, I think. Don't quote me on that. But the treatment of posterior puncture headache is fluids, caffeine, bed rest, and analgesics. Of course, you want to rule out meningitis, make sure there's no nuchal rigidity. You might need to send a CBC if you're just suspecting based on the timing. But if the headache develops right after the procedure, you know it's probably CSF leak.
Yeah.
Okay. Another complication from epidural, they're looking at epidural hematoma, so get the I'm sorry, abscess, so get the imaging sooner than later. And it's MRI with gadolinium is the gold standard. You want fever with the back pain, neurological deficit, whereas hematoma, it's just no fever, it's just worsening back pain with neurologic deficits. Okay, here they're describing trigeminal neuralgia, and it can be with V2 or V3. Carbazepine, oxcarbazine are the first-line therapies. Temporal arteritis, tender jaw, claudication, visual risk. How do you work that up? Biopsy and ESR, right? How do you treat it? Steroids.
Okay.
Cluster headache has autonomic orbital attacks. Occipital neuralgia is for posterior scalp pain. Okay, so opiate therapy, low testosterone. It is suppressing the hypothalamic pituitary axis, which is the next question. So we're killing two birds with one stone here. Reduced LH, FSH, decreased gonadal sex hormone production, fatigue, low libido, erectile dysfunction, amenorrhea, infertility, depression, and low bone density. Okay, which anticonvulsant gives gingival hyperplasia, hirsutism, ataxia, CYP drug interactions? It's phenytoin. Did you remember that one?
Yeah. Yeah. Well, it was the only one that made sense. So,
Right.
um,
Um, then wrong choices, duloxetine, serotonergic, and blood pressure, nausea, side effects, Celebrex. cardiovascular, renal, GI considerations. Clonidine causes hypotension, sedation, rebound, hypertension. Which muscle relaxant has a structure closely related to clonidine?
To clonidine. Oh.
Okay, I'll tell you. I'm just double checking myself here. I believe it is tizanidine.
Oh, okay.
That's why tizanidine can be associated with low blood pressure as well. The tizanidine, yeah, it has some alpha 2. It's an imidazole derivative structurally related to clonidine. Like clonidine, it is an alpha 2 adrenal receptor agonist.
Oh, okay.
Something to remember for the boards. They could ask you that.
Yeah.
Um, and just I'm looking up. So somnolence is a side effect of tizanidine, half hours, 1 to 3 hours. It can be administered up to four times daily. The clonidine, I'm sorry, the epidural administration and spinal administration of clonidine with local anesthetics and opioids is associated with enhanced analgesia, and therefore it will be expected that tizanidine may also have some analgesic properties in the epidural or spinal space, but we're not putting it there, so don't get any ideas. Spinal, this is really, I mean, I'm sorry about this one. He's leaning forward on the shopping cart. This is shopping cart sign, right? This is as obvious as it gets. But I think the more important thing is Babinski is upper motor neuron sign. Lhermitz is electrical shock with neck flexion. Tinel's is paresthesia with nerve percussion. And Koenig's sign suggests meningeal irritation.
Okay. I couldn't remember what Lermit was. Okay, it's electrical shock. But
Yeah,
I got the shopping cart, obviously, but
yeah. Also, slow burning, poorly localized pains the C fibers, whereas the A delta are the fast, sharp
oh,
pain
okay, good. I got that. I
fibers.
was like, I know A delta and C are both pain, but so great. Good. Okay.
Gamma fibers, muscle spindles, and A beta fibers touch, vibration, and can mediate allodynia after sensitization. So just keep that in mind.
The A
Um,
beta mediates allodynia. Okay.
Yeah, I mean, I think like okay, descending inhibitory pathways, which neurotransmitter is used? It's serotonin and norepinephrine,
Oh, okay, good. I just kind of guessed
right?
that, but
I believe
good.
glutamate is excitatory, so that's something to keep in mind. Um,
Okay.
so and histamine doesn't really, well, it does do a little bit with pain, but
Glutamate
not
is
as.
excitatory, not inhibitory like
Um,
GABA.
I'm pretty sure glutamate is excitatory. Let me double check.
Okay.
Glutamate, the most abundant primary excitatory neurotransmitter in the central nervous system. So yes, it is
Okay.
excitatory.
Okay.
And what's the problem with meperidine? Just off the top of your head.
The normoparidine metabolites, the normoparidine metabolites that they can cause seizures if you
Perfect.
have.
Another just key point, right, with the MAIOs, right? That's the whole Bell
Hmm.
Commission in New York. We had that issue where the ER doctor gave to that patient. She died. In addition, we used to put Demerol in our spinals. It had like local anesthetic structure, and it's like the way it was formed, so it had some extra analgesia aside from the opiates receptors. So anyway, spinal cord stimulator for refractory leg pain. However, it's not a perfect therapy, of course, right? So that's just something to consider. Plavix, spinal cord stimulator lead placement, obviously epidural hematoma. How many days you stop Plavix for before doing an epidural?
Three?
No, 7.
Is this 3-7? Okay.
It's
Okay.
7 days.
Okay.
Eliquis and Xarelto are 3 days.
Okay.
And Budapest
I always,
criteria is used for which condition?
you know what? I could not remember if it was, I put occipital neuralgia, but I could not remember.
It is CRPS.
It's CRPS. Okay.
So, okay, so basically, the criteria is you have to get let me just read the whole thing to you. This is important.
Okay.
This is test on the boards. I don't want to get it wrong, so just give me a second. Okay, internationally associated accepted guidelines for complex regional pain syndrome improves the accuracy by focusing on both patient-reported symptoms as well as what the clinician sees. So, you know, what, better if I could just bring up a chart for you here that shows it. Just give me a, you see my screen still, right?
Uh-huh. Yeah, I can
Oh,
see your
good.
screen. Yep.
Okay. Okay. Continuing pain disproportionate to any inciting event must report at least one symptom in three of the four categories: sensory, hyperesthesia, and/or allodynia, vasomotor, temperature, asymmetry, or skin color changes, pseudomotor or edema, or motor or trophic change. So they need one of those. And then they must display at least one sign in two or more of the following categories: sensory, hyperalgesia, pinprick, allodynia; vasomotor, evidence of temperature, asymmetry, or pseudomotor, evidence of edema or swelling; motor or trophic changes, decreased range of motion, etc., changes to the hair, nails, skin. So that's what that those are the options. Those are what the diagnostic criteria is.
Okay.
And I would definitely get familiar with that for the boards as well as for your practice. Okay, so moving on here. Do you do discography?
No,
Most of
I
us do
think
not.
yeah.
It's something that's fallen out of favor because of the it has what's the risk? First of all, it's a miserably
I guess
painful procedure.
cystitis is the biggest risk. Yeah.
Is discitis, right? So how does this discitis present?
Um, Severe back pain, fever,
Yep. How would you work
uh,
it up?
MRI,
And
and
what blood
maybe
test would you
some like,
send?
oh, I would get a white blood count and ESR, CRP.
That's right. That's what you're looking for. Problem is disc has poor blood supply, so you're talking IV antibiotics. So I do a lot of PRP. I used to do a lot of intradiscal PRP. Never had an issue. However, I'm having good results with peridiscal PRP. So I'm not even putting the needle in the disc so often. I'm just going around it, and it's working really well. Um, for that reason, to avoid discitis. Okay, widespread pain, sleepless, looks like fibromyalgia. And there's those tender points, which I think we don't have much time to go over, but you can look those up on your own.
Uh-huh.
Polymyalgia rheumatica has elevated inflammatory markers and proximal stiffness in older adults. Myasthenia is fatigue, weakness. Cervical myelopathy has upper motor neuron signs. L5 radiculopathy is focal and dermatomal. And the last question is what reduces the risk for cervical epidural? Another obvious one, which I
Yeah.
mean, like really, I'm sorry about that. So,